Moira Wong Orthodontics
presents Mr. Piet Haers in What is an orthognathic surgery?
Why do patients come to you? What for?
In terms of orthognathic surgery, they come to see me either because they have been made aware that orthodontics alone is not a good solution for them, that the underlying cause of a problem may well be the position of the jaws, or they come to see me because they have facial aspirations even after orthodontics. So an adequate bite has been created, but there's still facial issues. And more patients also come to see me after orthognathic surgery, in that they still have outstanding questions or things they would like to see changed, or they are not completely happy about. So those are the three main reasons why patients come to see me.
When you say facial aspirations, what exactly do you mean?
Well, it's a bit complex to explain, but orthognathic surgery aims to position the jaws where they should be in relation to themselves and in relation to the skull base, both in terms of forward projection, but also vertically, or in terms of asymmetry. And for instance, patients with asymmetry are well documented in the literature to have more problems accepting that as a positive self-image compared to patients with a symmetric face. Other patients have a very short face, so they don't show their teeth when they speak, some even not when they smile. And the opposite of that is some patients have a very long face, so they show way too much gum when they smile. But they, on the other hand, they cannot bring their lips together. The chin muscle is completely strained. Now, all those discrepancies in growth of the jaws affect the way you look. And the way you look then hence leads to a certain self-image, but that can also then greatly influence patients' self-confidence. Together with Moira, we also work with a clinical psychologist, Dr. Caitlin Marischal, and she can give you a whole psychological background about that. Number two, probably more important than self-image, although if you ask patients what was the most beneficial aspect of the outcome of combined surgical orthodontic treatment, they may well say my new facial appearance or an improved facial appearance. But number two, the position of the jaws also greatly influences all orofacial functions. And that to me is very, very important. Let me give you an example. Let's start again with the facial appearance. If you cannot show your teeth when you speak or when you smile, that reflects the facial function of facial appearance, of facial expression. People whom then may have an open bite, so the teeth cannot meet, or the lower teeth are far forwards, they may develop a lisp. So speech can be affected by the way your teeth and hence your jaws are positioned.
Oh.
People whom, for instance, have a very narrow upper jaw, they cannot breathe through their nose. The nasal airway resistance is such that they tend to breathe spontaneously all the time through their mouth. So nasal breathing is affected by facial growth, both in width, but also if the jaw is backwards. Finally, if both jaws are backwards, then you may well snore already at a young age, even with an ideal body mass index, because the jaws being backwards, especially if combined with rather a long face, that will lead to very little place for the soft tissues in the neck, the floor of the mouth, and the tongue, and they are pushed backwards, narrowing, again, the airway. And if the upper jaw is backwards, also the soft palate will be pushed backwards. So that leads to habitual snoring already in young people. But if they then get a bit older and may add a bit of weight, a combination of aging and a bit of weight gain may push them from snoring into sleep apnea. Sleep apnea means that whilst you sleep, you snore, and then at certain moments you stop breathing altogether. It's called an apnea. And if that goes beyond a certain length per episode and a certain episode per hour, which can all be measured, you really present with the clinical condition called the sleep apnea syndrome. Now that, on average, if not treated, can shorten life by 11 years, but it can also lead to lots of comorbidities, such as increased systolic pressure, increased blood pressure, increased risk of stroke, and all kinds of metabolic problems as well. So I start with the way you smile, the way you look, the way your facial mimics are rich or determined by either a very short or a very long face, which is very important for outcome for patients' personal experience, ending up with the sleep apnea, which is the opposite. Now, sleep apnea actually is the only medical indication to do that kind of surgery because it has the potential to be curative. Patients then do not need a CPAP mask. So within that whole spectrum of some issues with facial expressions relating to the jaw position and the tooth position, to the sleep apnea, strictly related to the way the jaws have grown, is a whole spectrum of reasons why people would come to see a maxillofacial surgeon to do orthognathic surgery or consider it. Something else is also very important. A lot of people who cannot breathe spontaneously at ease because the airways are narrow, they tend to extend the head forward to open up the airway. If you put them in a natural straight posture with a natural head position, there is an increased airway resistance. Now, the body does not want to spend energy on that. In other words, the moment they are no longer focused on having the correct posture and work to breathe, then they automatically will slip forward again with the lower jaw. And that causes postural problems, which A, is not healthy, B, can lead to problems in the neck. But those patients also have a somewhat higher tendency in starting to clench. So then they can get problems with muscles, the muscles of mastication, in normal English, the chewing muscles, right? Which are big one here on either side, and then the temple. This, what we call bruxism or clenching, can often in combination with other conditions lead to pain and problems in the joints. So all that can be related or can present on itself. So a lot of patients also see us, who present to us, complain of headaches, which are not headaches, but muscular spasm, or they complain of problems in their joints, which need to be addressed in themselves. But underlying habits, postural issues, facial structure may well play a role in those things occurring. Joint problems, we call it the temporomandibular joints, or multifactorial problems. And the way you bite is surely not on itself going to cause that. But the way the jaws are positioned, the way your posture is, indeed, and also somehow the way you bite, but also underlying bodily conditions influencing the inflammatory status of the body may make that a number of patients, in particular with short lower jaws, often in combination with a slightly longer face, that they have joint problems or muscular problems. So all those things need to be picked up. Finally, the patients with sleep apnea often diagnose that or get it diagnosed later in life. And that bit by bit now over the past 10 years is becoming the oldest patient group we treat, between 40, 50, sometimes even beyond, because there is a medical indication, as I explained before. as it can be curative for sleep apnea, and not only a functional indication in terms of biting, chewing, breathing, smiling, facial expression. So we now do more and more also patients in the older age group. And some come specifically for this, as there is more and more information that orthognathic surgery can cure sleep apnea. And people find that online in all kinds of search machines, Google, etc., etc. So a whole group of people from all age groups.
Well, thank you for that. That was really informative, and I cannot help but ask you how. I cannot imagine any child going, "I am going to be an oral surgeon." How did you end up doing what you're doing?
Well, that's a good question. My father was a dentist with a big oral surgical activity when I was a kid. My mother's cousin was professor of plastic surgery in France. So I was exposed to those professions in a way. But what then fascinated me most was indeed the face. Not in terms of disease, but in terms of probably the most characteristic part of communication. Is it now verbal communication when we speak? Is it now non-verbal communication? And facial shape, form, and function, and attractiveness, and doing something about that has always fascinated me. So with that kind of family background, and then being very interested in changing shape, in helping people with not only their appearance, but as I said before, all functions that occur in the mouth and the face combined, that is what motivated me. And the best example there I can give to you is cleft lip and palate. Now, children born with a cleft lip and palate, the first thing you want to do is replace that kind of collective identity, because all those clefts look quite similar, and bring to the fore, a normal baby face, right? Now, as that child, if well operated, grows, initially, everything looks very, very good. But then towards the age when the adult teeth come into the mouth, and then in particular during the growth spurt, you may see again some collective characteristics whereby that upper jaw doesn't grow well, it's behind. There may be issues with speech, there may be asymmetries, and ultimately giving those kids that kind of family identity in their face and eliminating the cleft identity gives them truly a big possibility to come to terms with their history, the way they were born, and come to terms with the fact that they now look like all the other members in their family, and that they can function as well as the other siblings or members in the family and other members in society. And I give that a little bit of an extreme example, because this is no longer to do with a growth disturbance of the jaws, but the growth disturbance of the jaws is kind of very often part of the cleft lip and palate history. And there you truly see that you can change people's life at a young age. So what fascinated me when I was young was to do things that improves quality of lives, gives you your chances, where your appearance in a way is not against you, as long as that appearance is somehow not normal, right? And giving that chance in the beginning of life seems to me as important as treating disease later in life in older patients. I was always interested in helping those kids younger in life. Extrapolating from the cleft lip and palate patient to the orthognathic patients, where there may also be facial issues affecting their well-being psychologically, I think these are very similar patient groups. And in orthognathic surgery, we now have developed interceptive techniques, things you can do already during growth, where you no longer need to wait necessarily till the end of growth, which is classically the age where we move the jaws because we know they are no longer to move away because of ongoing growth after the surgery. And doing those interceptive techniques at the age of 10, 11, 12, 13 can be so helpful for these kids in avoiding isolation, which is already somehow a risk in children in puberty, in that they can well become more introvert, you know. And again, helping kids in their well-being is for me so much more important than the way your teeth are positioned or any other little dental issue. So to bring it together, it's not about creating a bite. It is about creating a face with a functional bite in there, but all the time checking all orofacial functions and looking at what is now, I would dare to say, psychologically the most important for that patient. What can we give them? Do they understand that? But also, do they have realistic expectations about what can be done?
That was perfect. Thank you. And that leads very well on to my next question. You must have seen it in the list. I was going to ask you, what would your 10-year-old self say if he could see you through a time traveling tunnel? Do you think you have achieved a childhood dream with your career?
Yeah, I think so. There were many things I were interested in. Ultimately, I think what I now do, this profession is what I'm interested in most. And I might not have expected or being able to realize what I would achieve, because obviously a 10-year-old is not aware of the ins and outs of that profession and its challenges, its satisfactions. But if I had a second chance, I would do the same with a great, great, great conviction.
Okay. I do have to ask you now, I have to ask, after what you said, I have to ask, what are the biggest challenges of your profession?
Well, there are several challenges in our profession. One is you must know what you do in terms is you must be well informed in terms of literature, clinical insights, diagnostics, treatment planning. Then you must also have the dexterity to carry that out in reality. You must stay up to date. In other words, all new developments over time can prove to be valuable for what you do. Some other developments are more kind of temporary. They are a kind of a fashion and they disappear after a few years. And one has to remain critical and read a lot and inform himself a lot to really know where does that make sense for the patient. But I would say the biggest challenge you have is assessing patients, explaining to patients, and communicating that well so that they know what can be done for them, preventing them options from doing nothing to doing something minimal to go for the overall holistic comprehensive treatment. And then the other challenge in a way is the age. There are things you not always can do straight away. You have to wait. You must help them on the way. A lot of those patients also, they need to take into account the opinion of parents, even if they are already 15, 16, 17, 18, 19, 20, there is still a very strong parental bond. So convincing the family, or in the case of older patients whom already have a partner, convincing the partner that something can be done that is meaningful and is not based on vanity, but has a truly functional and psychological value is a challenge. And it is so important. I make very big efforts to truly make sure that the environment of the patient, is it now the family or the partner, that they are aware that what that patient wants may well be meaningful for them. and to create understanding and support for the decision that that patient ultimately will make to go ahead or not, and under which form, once they have been fully informed.
Wow. Okay, that does sound quite challenging. I mean, I'm not going to lie, not knowing what the final result would be is probably really scary for patients.
Yeah.
Okay. I did want to know, what do you feel are the positives and negatives of working with Moira?
Well, in all honesty, there are only positives, right? I worked for the first time with Moira already in 1999. That's a long time ago, isn't it? Moira has also had a very good training. She's very well versed in orthognathic surgery. She is open to multidisciplinary treatment. For instance, in some cases, we work together, not only Moira and myself, but also restorative dentists. If we need to add missing teeth after the end of treatment, especially in adults, that can happen. Or if the shape of teeth needs to be changed. So working on a multidisciplinary platform leads to the best outcomes. But the secret of truly being successful relies in both understanding what orthodontics can do, what surgery can do, both making a full functional analysis of not only the teeth and the mouth, but the entire face. And Moira is excellent in that. And ultimately, both knowing each other's what we can do, what we cannot do, and then working together, what we can do so much more. In other words, it is that communication. Communication in a team is the secret for success, and that is absolutely key. What is very important, I think, for us as a surgeon, as very often the orthodontist sees the patient first, is the orthodontist knowing where a patient may benefit from a surgical opinion. And again, if you limit that only to the position of the teeth, many patients will be missed who have other functional issues, as I have explained to you. Is it now nasal breathing, snoring? Is it now a lisp? Is it now facial expression or showing too much gum? A lot of those things start to indicate themselves by the way you look at the patient, the way they smile, the way they speak. And Moira is very good on picking up which patients may grow such that those things will become more relevant and ultimately need to see a surgeon to give them the option of a combined surgical orthodontic treatment. So I am absolutely privileged to be able to work with an orthodontist like Moira.
Wow, that's a high praise.
Yeah, and it's authentic, it's true.
So thank you. Then my next question is, if you can summarize the three most essential things that a person who is thinking that they may be a suitable case for an orthognathic surgery, what do they need to know in advance?
Firstly, they need to understand the complexity of the condition they present with. Often they come forward with one complaint or one issue they want you to address. But if you then question them well and have a good conversation with them, you quickly understand that there may be much more behind there. And either they are not aware that some things can be improved, or they would rather not bring that to the fore as their main motivation. So insight in their own condition is number one. Number two, then they need to understand very well what can be done for them and well, and what the burden of care is going to be for the different options they are presented with. By burden of care, I understand length of treatment, number of visits, number of surgeries, recovery periods. And with that, they need to understand also all potential risks and complications. Now, and that is very difficult. We need a certain hierarchy in insights when we make decisions. So a first consultation I mostly use to go with them through the complexity or simplicity of the problem they present with, and what can be done about it, from doing nothing to the most comprehensive treatment. And then I leave it there so that they can think about it. What is valuable for me? And then only in a second consultation, once they can come back with questions, where I also explain the burden of care, potential risks and complications, recovery period, impact on their sports or academic or professional activities. And then the third thing is to be 100% motivated. If patients are not 100% motivated, once they know where it starts and what it ends, and have had all information about all stages of the treatment, including the length of the treatment, with potentially some uncertain outcomes, only if they understand that can they truly tell you, yes, I want to go ahead. And there it is very important. On the one hand, we are all apprehensive to undergo surgery, all of us. So a patient must get over that apprehension and yet show trust and understanding and confidence, which is mutual between those who treat and the patient who receives the treatment. If that apprehension cannot be overcome, or if it turns into a significant anxiety, then there is a problem. The patient, in a way, comes to see you and wants to have something done because he is not satisfied with the way things are. But equally, they doubt that they can set the step towards treatment because of anxiety. And that is where the psychologist comes in one of her multiple functions, to talk that through with the patient and help the patient by creating better insight into their own personal dynamics to overcome that anxiety and reduce it to what I call, a healthy apprehensiveness to undergo treatment, where you are no longer under control, in particular if you would have a general anesthesia, right? So being informed and aware of the complexity, being aware of treatment options and all what they involve, including prognosis, potential risks and complications and impact on your daily life. That's number 2. And number 3, after all that, have a strong motivation to proceed, no longer to be hesitating. I do not think one should do elective surgery, which in a way is non-reversible in patients who are still hesitating. That is bad practice, unethical, and shouldn't be done.
That's a wonderful answer. Thank you so much. I completely agree with you. I do want to ask you a question that was it was sent to us by a patient online. So we told a few people that we will be having this this interview with you, and we asked them if they had any questions. So the question that we have from a patient was, is it possible, and I'll just read it out loud as it was asked. Is it possible to have double jaw surgery along with genioplasty, to be unhappy with the genioplasty positioning and how it has changed my face to looking witchy? So the patient feels like she looks witchy. Is it crazy to think about going back for more surgery to reduce the chin augmentation slightly? So what would you say to that patient? Is it crazy to think about additional surgery?
It is not crazy at all.
It's not?
No.
Okay.
When I see patients, I try to show them examples of patients who presented with very similar conditions and what can be expected. So they get a kind of a visual. But whenever a surgeon, however well he plans, which is mainly a clinical planning and also a dynamic planning, patient smiling, speaking, etc., but all that is nowadays translated into 3D data, and most planning is now done in digital, basically in a 3D controlled environment, right? It's called digital planning. You never know for sure how the soft tissues in the different parts of the face are going to follow the skeletal movements. And the planning can be wrong. or not satisfy a patient. And if the patient only is not happy, that is one thing. But if the opinion of the patient is reflected by the people around that patient, their friends, their colleagues, their family, then there is a very high likelihood that objectively, truly, something is not correct with that outcome in terms of aesthetics. And then it is worthwhile looking for a second opinion to see what can be done in order to further improve it, or should I accept it? And very often things can be done. And the same is true, people whom, for instance, have an open bite or a narrow upper jaw combined with an open bite, which is, in terms of long-term stability, maybe one of the most challenging things we do to remain stable. So you can have a relapse in that the bite goes back. Similarly, if you move a lower jaw forward, if the condyles are not very stable, you may see that the jaw walks back. It is not mandatory to accept it. Well, that's as good as it can be. It is worthwhile seeking a second opinion with the team whom have treated you or with other people to see, well, what now? Either the result is not stable or the aesthetics are not exactly to my liking. What can be done about that? And the third part of the answer to your question lies again in pre-operative patient information. It is about before you start to do all the talking, not afterwards, and try to explain to patients that you do your utter best. You use set criteria for the way you're going to plan. And it can sometimes go wrong, and not exactly as you would expect it to be in terms of how those soft tissues react to a certain skeletal movement, in that instance, the chin. And then build up the confidence, and then have the honesty as a surgeon to say, well, yeah, I understand that. It's not the best. It could be better. And then first and foremost to see if you would be able to do that, or if you would like to have a second opinion, or if the patient still has the trust for you to help them with a correction. Doing a second genioplasty is not a massive correction. Okay. There are much bigger problems if the surgical jaw movements are not correct, because this is a much more invasive revision surgery than a revision of a chin.
I'm pretty sure that patient is going to be relieved, because if it's just the chin, as you're saying, then she could just do that and probably feel a lot better.
It is possible that the problem can be solved by surgery on the chin only, doing it a second time around. Sometimes the position where the chin is influenced. For instance, if the teeth are far backwards and have not been brought forward, then you cannot just work on the chin, right? Then there is also an issue with the position of the lower lip. So in most instances, I think you can help by revisiting the chin area alone, but there are circumstances where the position of the mandible or the position of the teeth also are part of the solution to bring about a better aesthetic aspect of the chin. So it needs to be assessed in depth.
Of course. Well, thank you. Thank you for that. Now, one of the questions, I know that the answer will be very broad, but here we're asking for your opinion only. Is orthognathic surgery worth it?
That's not a question you should ask the surgeon. That is a question you should ask each individual patient whom has undergone the surgery. Patients may say it is worth it because of the outcome, as expected, as explained, and as realistically expected. Patient may have that outcome, but combined with a lot of complications, and then it may not be worth it. So, in my view, orthognathic surgery today in good hands can be done with a high degree of precision and a minimal amount of significant complications. I have seen patients with quite significant facial deformities who were happy with the results, And I've seen patients with very small, 3-4 millimeter small corrections, purely for the sake of the bite, the occlusion only, who were equally delighted. So a patient being happy with the outcome does not necessarily depend on the magnitude of the deformity, but depends on how patients are going to react to what has been achieved. And if that planning was correct and the execution was correct, and the patient has what we call a positive normal mindset, then I think the patients will be satisfied with the outcome. Again, clinical psychologists are ideal in assessing that and measuring that. Now, I have kids myself, and I helped thousands of patients with orthodontic surgery by now. And in the overwhelming majority, bar very, very few exceptions, are satisfied with the outcome. A last part to that answer would be the following. A young patient of mine who had what we call the upper jaw slightly backwards because of a cleft palate, which can negatively influence the growth of the upper jaw, had the surgery done in her early 20s. And then she set up a Facebook group to talk to other patients and came back with some data that in the meanwhile have also been validated by psychological studies. But a lot of the patients say, especially those you would operate after the age of 30, I should have done that much earlier. An extreme example of someone with an extreme facial condition that I do not want to go into details, whom we helped in his 50s after multiple surgeries elsewhere abroad. And everything seemed to fit. The facial appearance improved, speech improved, the bite was much better. And then the psychological analysis, which held him through the 5 or 6 years he was in treatment with us. Are you now happy with the outcome? He says, yes, but I'm even more depressed. And she said, but why? If you say you tick all the boxes. Well, he said, I'm even more depressed because now at the age of 53 or 54, I am aware of what I have missed out in my life by not having had this done adequately when I was in my late teens or early 20s. So that shows you the importance orthodontic surgery can have at a young age. It is also important to notice that people at the age of 16, 17, up to in their 20s, have a very, what I call, plastic self-image. In other words, we adapt very easily to changes in the way we look because we are still growing, we are still developing. And we don't have that fixed mindset about our appearance, our self-image. So that in itself is a good reason to do orthodontic surgery, if at all possible, and kids are motivated and well supported in that age group. Because we adapt so well to new function, to a new appearance, that you're surely going to have a positive outcome. There will be no self-doubt about the way you look. You can sometimes see in older patients. It is also an important moment in life where there is a discontinuity. There is a break. We leave secondary school after A-levels to take a gap year, to go into work experience, to go to university. And it is as if you can center the surgery around that break in people's life, that you close a chapter of childhood and adolescency and prepare them in a new way with a new look, which is much deeper and authentic than the superficial word look, right? For at the very brink of their adult life. So helping kids, adolescents in that age group is potentially the best moment to do it. And at that moment, apart from some few exceptions, growth of the maxillofacial skeleton of the jaws more or less has come to an end.
Wow. That was a very deep answer. Thank you. And I will ask you the last question and then I'll let you go. So the last question for tonight will be, considering the fact that when we answer that question, it could be seen by people from all over Europe. So would you say that it's a good idea for somebody to go abroad for their surgery?
Well, it is done more and more, and people are free, and people should surely consider the option to have second opinions. And I do not see why they would not look abroad. But I would dare to say that here in the UK, there are several teams of orthodontists and orthognathic surgeons who do very good work. I think the work I do with Mora is of a very high quality. I show my work in lectures I still do nowadays worldwide. Now it's via Zoom, but until the COVID pandemic started in March 2020, I was lecturing several times a year abroad about orthognathic surgery. And if cases were shown according to consent, etc., they were always my cases, and they were high-standing cases. So, and I'm not alone, you know. There are many of my colleagues who provide excellent work. So I would not say that there is need to go to Europe, but a lot of people have a very strong digital presence and are excellent in marketing, and they may well have a big call with a big following, and that may incite patients to go abroad and seek their opinion or having treatment abroad. The one problem there is always if you go abroad, and it is the same for people coming from abroad to the UK for treatment, and Maura and myself have had several patients coming from different parts of the world here to London for treatment, is once you're home, you're far away from your surgeon. So it has its advantages in terms of maybe getting options that are not around where you live locally, but the disadvantage is you're not necessarily close to where the surgeon is once you have traveled back to your home country. And for the orthodontist, you see, it is important that in a way they can communicate with the surgeon. And that is in my view, the unique value and the privilege I have, as I told you, working with Maura. We know each other professionally since over 20 years. And that creates that very strong communication and mutual insight in how best we can work together in helping patients. Working with a surgeon or an orthodontist whom you have never seen or met, and you don't know exactly their principles of treatment, may cause problems in that you're not at the same wavelength, and that then may be a small deficit in the quality you can provide potentially. But I think people should be free and go and get the information wherever they think they can get valuable information. But if they do so, they must ask all the correct questions to the people proposing treatment.
Wonderful. Thank you. Thank you
My
for
pleasure.
that. You have been absolutely fantastic.